Hello, I'm Dr. Donna Langenbahn, and I'm pleased to be presenting to you today. I'm a rehabilitation neuropsychologist at Rusk Rehabilitation, NYU Langone Health, and clinical associate professor of rehabilitation medicine at the NYU Grossman School of Medicine. Today, I'll be talking about cognitive rehabilitation, an overview and evidence-based practice. The objectives are here. I hope that by the end of this presentation, you will understand the difference between restorative versus compensatory approaches to cognitive rehabilitation, that you will know the 5 primary cognitive domains and the evidence-based recommendations for cognitive rehabilitation in each of those domains, and also to know the protocols that go with those particular recommendations. So, to talk about cognitive rehabilitation and what it is, it's a few things. It is indeed a systematic and functionally oriented intervention set based on assessment, neuropsychological assessment, and an understanding of the patient's brain behavioral strengths and deficits. Restoration cognitive rehabilitation means that we are really doing practice. We're trying to strengthen or reestablish previously learned skills and behavior patterns with repetition, really exercise drills. Compensatory rehabilitation, cognitive rehabilitation, is different. It really relies more on either internal or external compensatory strategies or devices. When it's internal, it's generally a strategy that is created by one's mind and enacted in behavior. For external compensation, we use devices, which I'll talk about more later, but devices like cell phones, calendars, etc. Cognitive rehabilitation is really geared toward building realistic awareness of the individual's strengths and difficulties, and uses clear and targeted feedback as a means of doing that. It also promotes the use of residual skills and compensatory strategies to reach goals, and it provides an opportunity for the individual to work on integration of old and new self-perceptions, and ultimately aims toward the individual being able to accept oneself, one's new self, if you will, and have a positive and productive quality of life. Evidence-based practice. Evidence-based practice was first talked about by Sackett and colleagues. It includes not only the evidence that we know from research findings and meta-analyses on those research findings, but also one's clinical expertise and taking into account the patient's values and preferences. There are 3 levels of recommendations in evidence-based practice. The highest level of recommendation is a practice standard or standard of care. This relies on substantive evidence of effectiveness in the research using at least one well-designed Class 1 study. That's usually a randomized controlled trial or RCT. A practice guideline is based on one or more class studies with some methodological limitations, perhaps, or on well-designed Class 2 studies, which are less rigorous than a randomized controlled trial. Practice option is based on lesser information coming from studies that do not have the kind of strength of a randomized controlled trial or even Class 2 studies. It can be more evidence from case studies, etc. I'm going to be talking primarily from a set of studies that I've been involved with, working with Keith Cicerone from 2000, the year 2000 onward. There are 4 of these, an original study and updates, and they are actually gathered together in a manual that is now published from 2023, edited by Eberle and Shapiro Rosenbaum. The cognitive domains that I'll be referring to today include executive function, attention and memory, as well as social communication and visual spatial skills. Some of the principles of cognitive rehabilitation, the ones that are most salient that I want to emphasize today are either restorative or bottom-up interventions and compensatory, as I mentioned before, or top-down. Restorative, as I said, are a set of interventions that target basic cognitive skills or functions such as arousal, attention, information processing. They directly engage the individual in practice of these skills, repeated drilling, graded exercises aimed at relearning the skill, really remedial kinds of work. Compensatory or top-down interventions address deficits generally in higher order executive functions through instruction and practice of principles, strategies, and rules or approaches that can be generalized across situations. I'll say more about this later, but top-down interventions teach guiding principles for task approach that can be applied across different contexts in different situations and are more generalizable. Other principles of cognitive rehabilitation include these. We think about challenge level. You make the task smaller or bigger in terms of its breadth, thus decreasing or increasing challenge level. You may change the length of a task, you may change the cognitive load of a task. All of these we devise and look at carefully in terms of fitting to the individual. We want to have a challenge level for an individual that makes the individual be able to cross that bridge toward a bit of a higher level capability, but that is doable, so that the challenge level is such that it gives the individual the opportunity to make a gain, to make improvement, but also provides the support and the structure to allow the individual to make that improvement. That leads us to structure. We give more or less cueing as needed, really leading to correct task performance. More about that later. We're gaining, hopefully, internalization and aiming for that so that as we fade cues for the individual, that person is going to learn and gain capability as he or she internalizing the skill being practiced. Executive function. Evidence-based practice recommendations for treatment of executive function impairments include practice standard level metacognitive strategy training, recommended for mild to moderate deficits in executive functioning, and a practice option for individuals with severe cognitive deficits to use errorless learning to promote performance of specific functional skills. Metacognitive strategy training, what is it? It's top-down training, as I mentioned. It reestablishes ways of approaching tasks, like having a calm attitude and how to sequence steps. It aims to improve the ability to monitor and regulate behavior. The therapist selects, teaches, and reinforces using compensatory strategies that enhance awareness and guide self-monitoring and error correction. And the goal is that the individual eventually is able to implement those strategies independently and adapt to new situations. One of the approaches that we use to train individuals is very simply a goal, plan, do, review approach. So in terms of approaching a task, the first thought is the goal. What is it that I want to accomplish? Once I have the goal, how do I plan to accomplish that goal? Listing the steps, but before I make that plan, I have to decide the pros and cons of perhaps different plans. So it's not just simply that I can decide on a plan, but it's really an analysis of what plan fits better in the context with the people that are involved, with the goal that I have in mind and with my resources. Once I've set on the plan, I execute the plan, and I execute that plan along with a strategy, keeping in mind what my goal is, and monitoring that I'm still heading toward that goal in the sequence of steps that really follow my plan. Once I'm done having executed the plan, I review. How did I do? How did it work? What worked? What didn't work? What would I change? This slide shows that an individual needs to have good emotional self-regulation before that person can set a goal, make a plan, and execute a plan. They have to have emotional self-regulation in order to think clearly and therefore be able to have effective problem solving. This slide shows that we want an individual not to be in a danger zone in terms of the strength of symptoms that they have associated with the brain injury. On a scale from 0 to 10, if you're in the red zone at a high 8, 9, or 10 level of intensity, you're not going to be able to think clearly, and you're certainly going to be in more danger of having an emotionally dysregulated reaction. You want to stay as much as possible and help the patient that you're working with gauge their symptoms so that they're really at a level of maybe from 1 to 4 in intensity, so that emotionality is not too intense and that clear thinking is possible, thus leading to good problem solving. One final slide in the executive function area is about errorless learning. Errorless learning is actually a memory technique that we use with individuals who have severe memory difficulties. The therapist presents information in a way that minimizes the possibility of making mistakes. So the patient presents simple information, not asking the patient a question first, but presenting the information and then requesting that the patient respond immediately. So I might say to you, "What is my name?" But I will first say, "My name is Donna." "What is my name?" So I'm telling the patient exactly what the answer is to the question that I'm going to ask. This is more effective also when combined with spaced retrieval or with a chaining technique where we use a number of steps with the individual and let's say leave off the last step. When we ask the question, we've just told the person the last step and ask the person to tell us the answer. Or putting more space in between the presentation of the information and the question that we ask so that eventually the person gets to internalize that information more and more. We're moving on to attention. The recommendation that we put forward in attention is that we combine direct attention training or exercises, drilling, along with metacognitive skills, so that at the same time that the person is doing the exercise repetition, we're also asking them to set a strategy to predict how difficult the task will be and what their results will be. We give them feedback after they've performed the task, and then we discuss their capability, their performance level, and whether their strategy worked. So the overall treatment is combined restorative and compensatory strategy training. The hierarchy of attention that we use for direct attention training is that set out by Solberg and Mateer in their famous book of 2001. The easiest level of attention training is focused attention. We may make that more complex as we go on by increasing the cognitive load. And then we move to sustained attention, selective attention, which is a matter of being able to focus and to focus out external noise or internal distractions. We teach people then to do alternating or back and forth attention, which is certainly something that happens all the time when we're at work or study. And then we go to working memory. Working memory is a kind of divided attention where we're holding on to certain information while we're performing operations or mental activity in another arena. We then need to go back and retrieve that original information so that we can combine it with the new information that we've been working on. Reading is a classic example of working memory, or two-step arithmetic problems on a more simple level where we have to hold on to information from the first step and then apply it to the information that we've gotten from the second step. Again, we're talking about metacognitive strategy training where we're really looking at having the person monitor, manage, predict what they're going to be doing, plan a strategy, use goal, plan, do, review in the task, and then assess how they did at the end of the current slide shows NBAC training. NBAC was devised by Keith Cicerone in an article published in 2002. The way it works is that N is a variable. N could be 1 or 2 or 3. And so what I'm going to do, if it's NBAC, I'm going to be told that my repeated practice is in learning with working memory how to remember the task that is one back. So as I go to the next card, which is 2, I'm actually going to say 6. So 6, 2, 7, king, queen, 7, that's my last card. I can make NBAC more difficult by saying a category after I say the NBAC card number, etc. Or do an alternating task and come back to it. I'll show you in the next slide. In this slide, you see how we can use this task at each level on the hierarchy or the pyramid. So we can add at the for focusing, we could add complexity by putting in a category so that before I say the card that is one back, I have to say the name of a fruit, for example, apple, card 6, pear, card 7, etc. For sustained attention, I may increase the number of trials or cards in a series of cards that I use. Selective attention allows me to increase background noise to the training session that the patient needs to focus out. Alternating attention means that I can alternate between 2 attention tasks. I might be using the NBAC task and task of reading and alternating back and forth. With working memory, I may use the NBAC task along with an ongoing secondary task. This is really good for people who may have high-level capabilities and need to go back to a high-level job. Memory. The practice standard in the memory domain is that we recommend for improved prospective memory and memory in everyday tasks for people with mild memory impairments, the use of both internalized strategies and external memory aids or devices. As a guideline, it's recommended that for individuals with more severe memory deficits, that they rely on external aids rather than internal memory devices. The components of memory, adapted from Solberg and Mateer, include 3 stages: paying attention, where where the memory for an event or information is registered; storing the information, that's where we use an internal strategy or device; and retrieving that information. For memory association techniques, which are more internalized techniques, we can use memory method of loci, where you can link information to specific or external visual references, reference points. Visual imagery, linking information to specific internal visual references, and sometimes increasing absurdity with humor or high levels of interaction can make the association stronger and the retrieval process easier. These are some of the external aids that we know about, or devices that are common really around the world at this point: notebooks, other written planners, cell phones, computers, calendars, etc. For prospective memory, a visual imagery technique that can work, that is kind of clever, is what's called the self-imagination effect. What this is that for 45 seconds, an individual imagines an event in the future from his or her own perspective, imagining the smells, the vision, the timing, so that if I think about this for a full 45 seconds very deeply, I'm going to be more likely to remember to do it later. Social communication. In this domain, the practice standard is that cognitive linguistic therapies are recommended during the acute and post-acute rehabilitation phase for language deficits secondary to left hemisphere stroke. In addition, at a standard practice level, interventions for communication deficits such as pragmatic conversational skills and recognition of emotions are recommended after TBI. Structured group treatment is really a treatment of choice for individuals with social communication difficulties. One structured group treatment comes from Dahlberg et al. In 2007 and has a structured format. Starts out with attendance and announcements in a group format, review and feedback, and then skilled exercises. Some of the skilled exercises have to do with voice quality, facial expression, body posture, sharing time, starting and maintaining conversations, being assertive or managing conflict resolution, and showing empathy. The agenda includes a summary of new learning toward the end and an assignment as homework for generalization of the information. Another aspect of social communication difficulties might have to do with emotion perception, because decreased social communication may reflect an inability to appreciate and monitor social cues. Bornhofen and McDonald in 2008 proposed treatment in small groups of 2 or 3 participants with starting with emotional contexts that would be known to the individual. So, for example, a birthday party or a scene from a birthday party might be used to ask the individual about what emotion would likely be shown in a birthday party. And of course, that would be happiness or fun or joy. Using static visual emotion cues in pictures is another form of being able to teach emotion perception, so that you point the person to the components of the face that are going to be changed for different emotions. And so in this particular picture with the woman smiling and her eyebrows up, she's happy. In this picture, the man has his mouth turned down, his eyebrows are furrowed, so he's sad. And in this picture, the woman has a rather disgusted look on her face and furrowed eyebrows. In the next picture, which is a little more complex, there are 2 individuals, 2 men, and the patient may be asked to say what might be going on between the 2 people in this context. Moving from static visual cues to dynamic cues, you can use therapist modeling, role play, videotaping with the individual, and also the internet provides some nice context for practicing with understanding emotional cues in a dynamic context. You also then can move to social inferences based on emotional demeanor and situational cues. For visual spatial skills, it's really important to understand about right-sided hemisphere difficulties in the form of hemispatial neglect that we know about. Hemispatial neglect, as shown on this picture, can involve difficulties in neglect of people and objects in far and near space, neglect of personal space, so that one may not even notice about not putting on makeup, a woman, or shaving for a man. Neglect in other perceptual modalities, so it may not be only visual modalities, but also hearing and tactile modalities. There's also the fact that individuals who have a hemispatial neglect may not look to the left. So the neglect of space on the left visually may not be compensated for because there's less propensity to look to the left to compensate. And finally, an anosognosia, or the unawareness of the neglect, which is a phenomenon that goes along with the left neglect syndrome. Practice standard associated with the treatment of hemispatial neglect is that visual scanning training is recommended for left visual neglect after right hemisphere stroke. In performing training in visual scanning, there are a couple principles that are really important. The first principle that's important is anchoring. The therapist gives verbal and visual cues at the far left and the right, if needed, of the visual spatial field. So full cueing would comprise a line, a vertical line on the left as a guideline for the individual, an anchor line, numbers for each line in reading, 1, 2, 3, 4 in this case, on the left, but also numbers on the right, so that in visual scanning, the person scans across from 1 to the number 1 on the right, back to the anchor line, and then 2 to 2, etc. That's the full cueing. It would be reduced one by one as the individual begins to learn the skill and also internalize the focus on the left side to combat the left neglect. Pacing is an important principle also in left neglect training, visual scanning. As you see here, a patient with rather severe left neglect moves rapidly, drifting over to the right. One way to prevent this is to ask the patient to recite the targets aloud. It makes the individual slow down and also be able to pace him or herself more appropriately throughout the entire field. Finally, the principles of metacognitive training should be applied in visual scanning also, where you ask the patient to predict his or her performance results, to provide self-feedback, and then the therapist provides feedback on performance, and there's a discussion. You plan together with the individual to increase strategies or change strategies if they were not effective, and then, of course, repeat task performance. Gestural apraxia is another difficulty that falls in the visual spatial area. There is a practice standard for treatment of this difficulty, and it is that specific gestural or strategy training is recommended for apraxia during the acute rehabilitation phase for left hemisphere stroke. Gestural training follows a 3-step treatment for transitive, intransitive symbolic, and intransitive non-symbolic situations. Playing the guitar is an example of transitive training. There is an object that we are focusing our interaction on. Treatment is restorative and works on prior complex motor skills. With repetition, again, we're hoping that people are able to restore, that they can be remediated to previous motor skill level. For strategy training, we're teaching the people really with instruction, assistance, and feedback and using strategies. The patient is taught by self-verbalization of steps to complete activities with levels of cueing or even physical help if needed. During feedback, the therapist points out results and helps the patient to self-reflect on results. This treatment is compensatory. and relies on the patient learning and practicing strategies and then to initiate them independently. Who benefits from cognitive rehabilitation? From our experience with practice, we find that the individual who's going to benefit has to be willing to make change, have the capacity to learn, and have no behavioral or emotional obstacles that will prevent them being able to pay attention or to participate in the treatment process. These are the references that are included in handouts. And I thank you and ready for questions and answers.